So the next speaker is Professor Simon Fishel. And Simon is one of the pioneers in embryology, one of the students of Bob Edwards at the Department of Physiology in Cambridge, and started from the very beginning in Bourne Hall. And after that developed his own way. And recently he is now CEO of the care groups in the UK and also some other part of the world. He also published quite extensively and did a lot of scientific but also clinical embryology work in his lab. Thank you, Simon.
Thanks, Robert. Thanks, David. So thanks also to the organizing committee to invite me back to Paris and just to share with you some new stuff that we've been doing. It's something that it's fairly recent. We've actually published it recently, and it struck our imagination. So what I wanted to do is to share with you some of our work and the results and what we've learned from that, and just to see whether or not we have some prospects into taking this study a bit further. But I know we're late for time, so I'll try and do what I can to make it up to you all, because I'm sure you want to get to some lunch. So what we've been working on is, just see where the laser, is there a laser on this? Yeah. So we've been looking at this ANXA5 M2 haplotype, and potentially as a biomarker for antithrombotic activity that we may be able to treat, we assumed, by the standard approach of low molecular weight heparin. And one would ask again, why another study on, there's been thousands of trials regarding low molecular weight heparin. Well, I hope that something will become clear during this talk as to why we're interested in this. Just to say, it really all started out very early on with the work here from the Funakoshi colleagues and their lab in 1987, when we can see that they, oh, sorry, I see why Jeremy's struggling here, okay. They extracted an anticoagulant protein from the soluble fraction of human placenta. And they said that it prolonged factor X-induced clotting time of platelet-rich plasma, but did not affect the thrombin-induced conversion of fibrinogen to fibrin. And that sparked quite a lot of interest. And eventually, as we well know, there was a whole raft of annexin proteins that were discovered, and the one that we're interested in here is what is known as ANXA5. This had previous annotations, but we now know it as ANXA5. And so that's the particular gene and the particular mutation of that I'm going to be addressing in this short study. Then there was a study by Rand et al. In 1997. And they looked at the pregnancy loss in the antiphospholipid antibody syndrome and looked at the thrombogenetic mechanism. And we can see here that they concluded various aspects of ANXA5 and its role in the acceleration of coagulation of plasma and the effects of that. In fact, I won't go through all of this now just because of time. I'm sure a lot of you know more about the coagulation process than I do, a wonderfully complex procedure, but it was quite clear that the annexin itself was a major component, and any disruption of the production of that protein may well affect the early placenta. And we know what we know about the annexins, that they're a family of proteins which share the properties of binding calcium and phospholipids, and the phospholipid binding property is associated with anticoagulant activities, and these are a consequence of the inhibition of critical phospholipid-dependent coagulation reactions. So what the current information is on these proteins is that it's essential for repair and maintenance of the syncytial trophoblast, an apical membrane. Without this efficient repair mechanism, coagulation occurs, and this will affect adversely the embryo, early implanting embryo, and the fetus during pregnancy. So precise remodeling of the uterine spiral arteries during the early stages of pregnancy is necessary for a healthy outcome. And if we get defective placentation, then we get impaired trophoblast invasion. Failure of sufficient remodeling of the spiral arteries are common, and we will get adverse pregnancy outcomes, including early pregnancy loss, intrauterine growth restriction, preeclampsia. And this is what we know as placenta-mediated pregnancy complications. The syncytial trophoblast has an enormous amount of important functions, and importantly, this is the invasion of the maternal myometrial spiral arteries during the first trimester. Around 8 to 10 weeks it completes, and by 20 to 22 weeks of gestation in normal pregnancy. We heard about the size of the epididymis earlier, and actually the surface of the syncytial trophoblast is also huge. It's 5 square meters at 28 weeks, and up to 11 to 12 square meters at term. But we all know the function that the trophoblast provides, so I won't detail that just now. But here we see a diagrammatic representation of a whole raft of pathologies associated with the actual ANXA5. So we've got recurrent pregnancy loss, preeclampsia, gestational hypertension, fetal growth restriction, maternal venous thromboembolism, polycystic ovarian disease, antiphospholipid antibodies, small for gestational age. The majority of problems arise in terms of recurrent pregnancy loss about 5 to 12 weeks, and the range is about 5 to 23 weeks. So there's a whole raft of placenta-mediated related complications that we have been recorded with any problems arising in ANXA5 particularly. So it's the actual mutation, the ANXA5 M2 haplotype that we're interested in, is a 4-base permutation in the ANXA5 gene, and it causes a reduction in ANXA5, and it's present in the syncytial trophoblast. So that's the basis around the interest in this particular mutation. It's present on 4q27 of chromosome 4, and we can see here there are 2 haplotypes. There's M1, and here we see the wild type, GATG, and then you've got GCCG, and then you've got the M2 haplotype here of ACCA. And the variants were initially found with a systematic sequence analysis of the ANXA5 gene in 70 patients in northern Germany. And this is the work coming out of Münster University. And the origin was with reproductive pregnancy loss patients. And that was defined as more than 2 fetal losses. And they were non-carriers of PTM, the prothrombin mutation, or factor V Leiden mutations. And then since that original publication, the work was done, as we'll see in a minute, around about the mid-2000s, 2007 particularly. There's been 4,500 patients of different ethnicities, and various obstetric complications have been genotyped. Okay. So I want to look at here the studies that show the M2 haplotype being linked to significant reduction in annexin. So the reported gene assay in M2 carrier women with recurrent pregnancy loss showed in vitro reduction of the ANXA5 promoter in 37 to 42% of women. And this is this very early study by the Bogdanova group coming out of Münster, which is really quite critical to this work. Expression of ANXA5 messenger RNA and placentas from M2 carriers with PE and FGR significantly 3 times lower than normal non-carriers. And that was the work published in 2009 by Chinny et al. And it was also shown that haplotype resulted in a decrease, 42% decrease of placental MRA levels in heterozygous carriers compared to normal non-carriers. And that's the work of Markov, who's been really instrumental in driving this work forward. So the studies to date, in terms of case and control genotyping, are shown here. So there's 4,592 cases with 2,577 controls. The work that was originally done in Germany, there was 2,750 affected patients and 1,660 controls. There's been work done in Italy, as we can see here, 307 patients and 195 controls. And there's been work done in London now, in Imperial College, more recently. And also, there's been work done in Japan. And interestingly, the carrier rates of the ANXA5 M2 haplotype are shown here. In the European, the general population tends to be about 15%. With recurrent pregnancy loss, its exposure is about 24 to 34%. In the Japanese general population, it's about 5%, with RPL cohorts of 11% exposure. And in the Malay population, it's 42%. And in all the RPL groups, it's about 52.6. So we can see the ethnic diversity here. Also, there's been some work done with knockout murine model, the mouse model, and this, in a sense, drove the plausibility for the use of low molecular weight treatment in M2 patients. So the work by Yuki and colleagues, and this work was done in 2012, shows significant reductions in the litter size and fetal weight of ANXA5 null mice. Low molecular weight heparin then given to these knockout mice significantly reduced pregnancy loss, and maternal ANXA5 was crucial for maintaining intact placental circulation as the obvious conclusion of that in this study, and it minimized the risk of thrombosis in placental circulation, which, of course, reduced the fetal loss. So that, in a sense, gave a drive for us to look at this as a more focused option in patients. There was a study of the pathology of the M2 placentas, as we can see here, from the work of Otter et al. In 2013, in terms of preeclampsia. They compared the pathology with controlled pregnancies and found that the placentas carrying M2 haplotype showed significantly more severe perivillous fibrin deposition, that's the PVFD, and that was highly significant. And this suggests that low levels of ANXA5 at the fetal-maternal interface in the chorionic villi of M2 placentas contributed to the onset of preeclampsia. So, in a sense, this is the backdrop to what we were interested in doing. But why we were interested in, a lot of the studies that have been done, importantly, are not stratified by both parent characteristics, only the female, generally. And treatment with low molecular weight heparin in the normal clinical practice occurs generally from about 5 weeks because there is uncertainty in routine miscarriage clinics as to exactly the point of conception, of course, obviously, and so they can only begin treatment at a time when actually it's a bit too late. As M2, the clinical pregnancy losses we know from the M2 haplotype start at or before 5 weeks. So we thought the IVF population was actually an ideal group to study this. And why we still want to persist with low molecular weight heparin. I wanted to add in this work here by Ian Greer and Nelson, because I think it's very important that they pointed out quite critically that it's the precision approach, precision medicine is coming, as we know, as to why we do not see benefits in many of the trials, and there are, as we know now, there have been many trials with the use of low molecular weight heparin that haven't shown benefit, because there isn't a precision approach to particular markers that suggests the use of low molecular weight heparin being an advantage. So I'll actually move on from this, just because of time. So this is what we wanted to do. Our premise was it was a potential biomarker, very specific, precision medicine approach, and its present may be deleterious to the establishment and maintenance of the placenta, and it may be a reason why so many embryos still fail and pregnancies still fail, even, for example, when we know we're putting back a euploid embryo. So the first thing we did was an incidence study, and that incidence study showed us, actually we were quite surprised, in the patients that we looked at, and this has been published, it was a high incidence of about 44%, 45% in couples, with equiprevalence in the male and the female. So it's 26% in male, 24% in female. So actually, this was about the first time we knew, or we hypothesized that the man would pass on something that would potentially cause a miscarriage in the woman. Both partner carrier status we found was approximately 10%, couples 44%. Couples with unexplained infertility in our cohort, 37% were carriers. It coexisted with male and infertility patients together in about 27%, and PCOS it coexisted at 35%. I just want to point out, for those who are interested in the difference between that and factor V lindin and prothrombin, we can see here the incidence in the general population for ANXA M2 haplotype is higher, and actually you can see here the incidence in IVF females, 24%. Also, just quickly here, look at the known hereditary thrombophilic risks for these factors here, antithrombin deficiency, protein C, etc. We can see in the normal population it's very high. Sorry, some of you may be confused by C4M2, that's chromosome 4M2 haplotype. It's just the shorthand that we used for what is actually the same haplotype that we're looking at. And we can see here the relative thrombotic risk. It's actually 3 times in its own right, but it's additive to the other thrombophilias. So it's a distinct thrombophilic issue from the other thrombophilic components that we know. So then what we decided to do was to do a pragmatic prospective cohort study. And just let me take you through this. So we had a tested and treated patient cohort of 103. So we screened 696 patients. So couples was 369. You have to screen the partner. We don't at the moment screen donors, either eggs or sperm, but we always screen the male of a couple. And all the M2 positive couples were treated with low molecular weight heparin. And the female was given 40 milligrams daily from the day of oocyte retrieval for fresh embryo transfer, and obviously embryo transfer if frozen. Advised up to 12 weeks, minimum 12 weeks, advised to delivery, and it's also the advice that's given is if the woman is the carrier post-delivery, we'll also give it for 6 weeks because of the higher risk of VTE. Sadly, of course, because this is too new and they go into the general population, their obstetricians advise them to stop the heparin very early on, and we did lose a few on the basis of that, we believe. The next group we looked at was untreated couples. Now, we call this the yardstick group because they were screened retrospectively after failure, and we screened 171 females and 154 male partners for the haplotype after failure, and they weren't treated, obviously, with a low molecular weight heparin, and we had those in there for a particular reason, which I'll show you in a minute. And we compared it to a retrospective contemporary control group of 1,000. And from that 1,000, we then selected 103 couples randomly that actually paired with the untreated control group. And you can see here the outcome. So let's have a look. The control group median age was 35, and the number of years of infertility was 3, whereas a treated group, that's the 103 that we're talking about, with one or both partners a carrier, the median age was 36 years, and the years of infertility was 5 years. Treated group were significantly older, and as we know, once you've got a significantly older group, in the data that we've got based on thousands of cases now, you've got a drop of about 9.2% per year on the odds of a live birth. So actually, the controls were older, but as you'll see, the outcomes were particularly favorable. 55% of those treated were greater than 4 years infertile, compared to 28.8% of the controls. Of the matched control group, that's the tested and treated cohort was matched with a cohort of 103 retrospective untested, as I mentioned before, drawn from the 1,000. None had achieved a live birth previously, and they were matched on either egg recipient or standard, numbers of embryos transferred, embryo type, female age, previous failed IVF cycles, and previous miscarriages. The yardstick group were patients who initially had IVF failure or miscarriage, but then elected to be screened for M2 and were positive, and were included, and this is why they were included, to observe the pregnancy stage loss. And actually, they're not true controls, obviously, because of their selection, but they were selected on their previous failure, and in all other respects were similar to the control, except they had actually a higher incidence, 2 to 3 failed cycles, 23.4% versus 9.2% of the controls. And here's just the profiles of the yardstick group here. You can see that very quickly. Now, most of the controls were 0 to 4 years infertile, first-time IVF, 5% recurrent pregnancy loss. The treated were 49%, 5 to 9 years infertile, 46.6%, 2 to 3 failed cycles, and 17.5% recurrent pregnancy loss. And what we found when we screened the screening and treating those that were carriers, they achieved the same live birth rate, 38% per embryo transfer cycle, as the statistically younger first-time IVF couples. So we believe that their chance of a live birth was restored to the controls when they previously had only ever had failure or recurrent pregnancy loss. So that they were not affected by the data as you see here. The type of incubator we looked at, intralipid, because there was a clinical option, of course, if they had other thrombophilic disorders and there was treatment, we had to account for any form of other treatments, and the main one was intralipid, and that had no bearing on the pregnancy outcome. And this was recently published in the Lancet's eBiomedicine journal online, where we believe with the positives that are untreated, we don't see a live birth, whereas we see a live birth almost up to the same as the normal controls. I can see the time is running out. Just want to point out something here. If we look at this yardstick group, it does appear, and here just to clarify this actual table for you, this is the unscreened, untreated group. This is the yardstick group. And when you compare the two in terms of the loss, now this is the actual loss here, how their pregnancies failed. The implantation incidence was 4 versus 10.4%. Biochemical pregnancy rate, 16.5 to 37.3. And the clinical pregnancy rate here, 5.6, 16%. We actually see in this yardstick group, they actually do reasonably well until they actually get to the post-implantation period, where they have an enormous drop-off later on, and all of them lost their pregnancies. So it appears just in, this is similar data here, but I'll go straight to the conclusion for you. It appears that although they had high rates of pregnancy loss at various stages, their implantation incidence and clinical pregnancy rates were significantly higher than the controls. They could get that far. They did very well. The problem was that all the clinical pregnancies were lost entirely at 5 to 12 weeks. So we believe that they do have a different pattern of pregnancy loss compared to unscreened patients. Just some other, I'm going to finish off with actually some specific information for you, comparing couples with only males who carried versus the couples where only the female carried. Live birth outcome was statistically higher in the male carrier-only couples, 58.3 versus 25%. Let's move on from this. So in terms of summary of published work, which I think is a very important backdrop to this, that we know that carriers of the ANXA5 M2, they do now face a twofold higher RPL risk compared to the general population. The relative RPL risk grows to 3 when the number of miscarriages is taken to be 3 and above. There's a 4-fold increase in the risk of early pregnancy loss when you compare them to fertile controls. There's a 2-fold increase in risk of other factors, gestational hypertension, PE and VTE. 3-fold increase in the risk of restricted fetal growth. 2.6-fold increase in the risk of small for gestational age babies, and a 3-fold relative risk to develop APL antibodies. It's present in approximately 30% of the PCOS population. The risk appears to be dose-related, and this has recently come out of a UCL paper, Imperial College, by Demetriou et al. And Leslie Reagan's group. Couples with a total of 2 alleles, both partners are carriers, or one of them is homozygous, again, you get a significant risk of RPL than control couples. 1 or more of the alleles plus additional thrombophilia also elevates risk. Now, interestingly enough, that was their conclusion. We didn't find that in our study, and we didn't find that the effect of the allelic dose reported by Demetriou et al. Was observed, and it may well be because of the use of the low molecular weight heparin. As you can see here, there's risks if both parents are carriers. There's a 64% inheritance in the Demetriou's study, and this was 47 control couples in their particular study, and it was inherited by 30 children, 64% inheritance. And small gestational age, all female homozygotes had a history of severe SGA, and that's a study that came out in 2012. So just to conclude, identification, we believe, of the ANXA5 M2 haplotype, which can be carried in either partner, allows a precision approach to use for low molecular weight heparin. The advantage of looking at this in the IVF population is we can get in early with treatment, which gives us the maximum opportunity to minimize any potential deleterious effect. We're not sure yet whether we ought to be screening donors for this, because it's an interesting one. We certainly will screen the patient that we're treating, but to go and screen donors is an interesting debate. And we believe it's particularly important for patients aged 35 plus, those with a previous phase cycle, miscarriage, or unexplained infertility. And it does achieve, with treatment, we believe, once the presence has been identified, an acceptable live birth rate similar to the control. So who knows? It may well be, when you see those groups now that are transferring only euploid embryos, they do 100% PGS, and they get very high pregnancy rates. There's still something like a 25% loss from transfer to live birth. So this could be a factor, one of the other many factors that is reducing opportunity for our IVF patients. But I think all the data that's been coming out of the recurrent miscarriage world related to this haplotype suggests that it's something that we probably ought to be incorporating and looking at in the IVF field. Thank you very much.